Coming to the physical examinations, any complicating factors, pneumonia, anaphylaxis, or any of the comorbid conditions that can lead to even shortness of breath, pulmonary embolism, CHF, pulmonary infection should be ruled out. Objective assessment, of course, spirometry is there or a peak flow meter, but this PEF, if you are doing a spirometer, this PEF levels can be calculated on the spirometer also. Oxygen saturation, if the patient is there in your hospital setup, check the pulse oximeter. So if the patient is a chronic COPD or asthma case, generally his baseline oxygen saturations will be between 88, 90 or 92. You cannot expect a patient of maybe COPD or a chronic asthma having oxygen levels greater than 96, 97 or 98. Get a ABG done so that the patient will come to know whether he is in a respiratory acidosis, alkalosis or a metabolic acidosis or alkalosis. Get a chest x-ray done and send a all routine battery of investigations. But before administration of any of the antibiotics, do send a routine investigation, battery of investigation. But the baseline, which is there at each and every settings, get a X-ray, get a ABG, monitor the oxygen saturation levels. But generally in exacerbation, you don't perform a spirometry. So once you settle the patient, if the patient is settled, and then you go for performing the patient of doing a spirometry. ABG in acute asthma are indicated when the patient is having dyspnea, PEF less than 25% of the normal values, or PEF 25 to 50, whose respiratory status is deteriorating even if the patient is on intensive therapy. Patient who are too ill to perform a peak flow measurement, that is peak flow meter, and demonstrating signs and symptoms of CO2 retention. The patient is getting dull, the patient is getting drowsy, there is slowness of the respiratory rate, there is bradypnea, there is myoclonus. So get a ABG. But again, even if the patient is of asthma or a COPD exacerbation, ABG is a must. You do a ABG in both the cases. Features suggesting an alternate or comorbid condition, so concomitant symptoms like purulent sputum production, urticaria, pleuritic chest pain. Look out and rule out the other diagnoses, especially bronchiectasis, pneumothorax, because COPD patients are more prone to develop pneumothorax, maybe hydropneumothorax because of that bullous lung disease, because of that bulla underlying development of small cyst, air-filled sacs which are being there. So a chest radiograph should be done. A complicating cardiopulmonary process is being suspected if the patient is having fever, temperature, unexplained chest pain, leukocytosis or hypoxemia. So unexplained chest pain can be there because of pneumothorax, because of hydropneumothorax, leukocytosis, more temperature that suspect underlying secondary infection, mostly bacterial, or a hypoxemia. So you do when a patient requires hospitalization, when a diagnosis is uncertain, go for a chest radiograph. Chest radiograph is a very good, very cheap, very good diagnostic modality. Until and unless the patient is a female, the patient is a pregnant female, then of course. But again, likelihood of COPD in a pregnant female, maybe that things are comparatively less as compared to the males. So detecting an exacerbation, what exactly is an exacerbation mean? Exacerbation is worsening of the signs and symptoms. A patient of asthma and COPD will have shortness of breath, will have cough with expectoration or maybe a dry cough, will have maybe respiratory infections on and off, especially COPD. But if that signs and symptoms are more flared up, that is not being controlled, even with the medications, that is known as exacerbation. So look out for the symptoms, look out for the risk factors for fatal asthma.